Welcome to Advanced Practice, where we brew together excellence in mental health practice. In the previous episode, we explored valproate and the expanding recognition that bipolar disorder was far more complex than simple euphoric mania. As psychiatry evolved, clinicians increasingly encountered patients struggling not only with manic episodes, but with persistent depression, emotional instability, cognitive slowing, and functional decline between episodes. Many patients with bipolar disorder spend far more time depressed than manic. Bipolar depression often became the dominant source of disability, impaired functioning, suicide risk, and reduced quality of life. But treating bipolar depression proved difficult. Traditional antidepressants raised concerns about mood destabilization, switching into mania, rapid cycling, or worsening mixed features. Meanwhile, many medications effective for mania did relatively very little for depressive symptoms. And this created the perfect environment for lamotrigine to emerge. Originally developed as an anticonvulsant, lamotrigine eventually gained attention for its potential benefits in bipolar depression and maintenance treatment. Unlike lithium or valproate, lamotrigine did not become known for controlling severe acute mania. Instead, its role centered more around depressive relapse prevention and long-term mood stabilization. And that distinction matters. For years, the phrase mood stabilizer was often used broadly to describe medications used in bipolar disorder. But clinically, these medications do very different things. Lithium strongly targets mania and relapse prevention. Valproate often performs well in acute mania and mixed states. Atypical antipsychotics vary widely across manic, depressive, and maintenance phases. Lamotrigine, however, appears more effective in reducing depressive recurrence rather than suppressing acute mania. In other words, not all mood stabilizers stabilize the same part of the bipolar illness. Lamotrigine's mechanism is not fully understood, but it appears to modulate voltage-sensitive sodium channels and reduce excessive glutamate release. Clinically, many patients describe it differently from more sedating bipolar medications. Rather than feeling behaviorally suppressed, some patients report improved emotional consistency, cognitive clarity, and functional stability. That profile made lamotrigine particularly attractive for long-term maintenance treatment. Another major advantage is tolerability. Compared with many other bipolar medications, lamotrigine is generally considered metabolically favorable. It is far less associated with significant weight gain, diabetes risk, sedation, or prolactin elevation. For patients concerned about cognition, energy, or long-term medical burden, these became highly relevant. But lamotrigine comes with one major challenge: titration. Unlike many psychiatric medications that can be rapidly escalated, lamotrigine must be increased gradually because of the risk of serious rash, including Stevens-Johnson syndrome and toxic epidermal necrolysis. Although these reactions are rare, the concern significantly shaped how the medication is prescribed. Rapid dose escalation, restarting at high doses after interruption, or combining lamotrigine with valproate can increase risk. As a result, lamotrigine titration became one of the most protocol-driven processes in psychopharmacology. Treatment commonly begins at 25 milligrams daily for 2 weeks, then increases gradually over several weeks toward maintenance doses, often ranging between 100 and 200 milligrams daily. Though some patients may require higher doses depending on metabolism, drug interactions, or clinical response. It is not typically the medication clinicians reach for when a patient is acutely manic, severely psychotic, or dangerously agitated. Instead, lamotrigine often becomes part of a broader strategy focused on long-term emotional stability, depressive prevention, and preserving functionality over time. Another interesting aspect of lamotrigine is that it tends to generate unusually strong patient loyalty. Some patients describe it as life-changing, while others experience minimal benefit. This variability highlights another reality of bipolar disorder. Treatment response remains highly individualized, and psychiatry still lacks precise biological predictors for who will respond best to which medication. Well, that's it for today. Thank you for joining us on Advanced Practice. In the next episode, we will move into one of the most transformative developments in modern bipolar treatment: second generation antipsychotics. See you soon. Bye.